Hello, everybody, and welcome to a new episode of Home of Medicine podcast. My name is Ben Lovell. I'm a doctor working in London in acute and general internal medicine, and my podcast buddy is...
Hi, I'm Dr. a.burbridge, a consultant in acute and general medicine working in Coventry. How are you, Ben?
I'm okay. As I was saying to you just now, I'm on the tail end of a cold, so I'm a bit croaky. And if I blow my nose, I will mute myself first because that is revolting to listen to. For anyone, and revolting to watch for anyone who's watching us on YouTube, because of course we have a YouTube channel where people can watch us make faces at each other as we do these cases. So people don't like it when we waffle too much. So I'm going to jump straight into a case, and I've got a case for you, if that's okay.
Yeah.
And I'm switched it up a little bit this week. This is not so much a case of can you work out what's going on. It's a case of, I know what the diagnosis is, but what am I going to do? So I'd just like to know what you do in a situation like this, and we can sort of talk it through that way, if that's okay. So I am on call, on take, and I'm seeing a new patient, and the patient is in resus. And the reason they've been moved to resus is because of their blood test results. The background is, it's a 74-year-old patient, and she was asked to come into A&E by her GP. Because her GP had done bloods, routine bloods in the GP surgery 2 days ago. And when you do bloods in a GP surgery, there's a bit of delay to get your results back. And the results came back today, and they said, your sodium is 119. Please go to A&E. Obviously, this result is already 2 days out of date. And the patient herself was sort of surprised because she thought these were routine bloods. They weren't blood tests done for a symptomatic reason, but she duly presented to A&E for assessment for this abnormal blood test result. And the important background for this patient is that she is someone who has bladder cancer, and she has had two procedures, resections of tumors for the bladder, and she's been through a cycle of chemotherapy, and she's just completed 4 months ago another cycle of what was termed in her medical notes as palliative chemotherapy, and she's known to have metastasis to bone. So she is now in the palliative stage of treatment. However, this 74-year-old woman is very active. She still goes out a lot. She lives independently with her husband. She got an Uber into hospital where she got put into resus. And I think that's useful information to me when people say, and I say, how did you get here to hospital today? And they say, I got the bus. That really sort of presents the case a bit differently in my mind than someone who was slung into the back of an ambulance. So she made her own way in. So I go and meet her and say, how are you feeling? And she says, I'm feeling a bit tired. I've had a sort of a general malaise for a couple of days, but otherwise I'm quite surprised that my GP rang me and said, go to A&E about this blood test result. I've never had problems with sodium before, with salt levels in my blood before. So I'm a little bit bewildered by what's going on. So I assess the patient, but at this point, I'll just stop for a second. We're dealing with a case of hyponatremia. It was 119 on our bloods, actually, which was the ones today. And the one in GP surgery a couple of days ago was around about that as well. What information do you look at or look for when you're assessing a patient with hyponatremia, and why?
Okay, so firstly, I think you've already answered my question, but I want to double check that the sodium is definitely 119. So you said that it was 119 at the GP bloods. So repeat it to make sure that this isn't a spurious result and to make sure that I'm not going to be over or under treating. That is key. Number two, I'm just going to put this out there, but I have neurophobia is my top phobia. Number two is hyponatremia phobia. And it doesn't matter how often I read the guidelines on hyponatremia or how often I manage it or teach it, I still forget it. It goes in 1 minute and then the next minute it disappears. I have no idea why. So practically, however, I've got this patient in front of me. Sodium's 119. I do the end of the bed test. Is she well? Is she unwell? You said she got an Uber to hospital and she's very well. That's reassuring. I get really worried when patients are hyponatremic and they are confused and they've had a seizure. So that's when I start to get worried, but she's well, she got an Uber into hospital. Fantastic. Number one, I need to assess her fluid status. So is this low sodium level associated with dehydration or overhydration? Or is she euvolemic or just a normal fluid volume status? So that's the first question I want to ask. And then in the back of my mind is medication. What medication does she take? So that's where I'd start.
I'm the exact same way, but the other way around. First of all, I go drugs So
Oh,
when someone's
okay.
got hypotonia, the first thing, oh, what have we given them? It's always benzoyl it's always indapamide. There's always a drug. So I go straight to the drug list first of all, and then I go to fluid status. I'm going to rant a little bit in this episode about the common hyponatremia guideline, the algorithms that we all follow. When you say you have to look it up every time you see it, I think you mean you look up the that decision tree, the algorithm where it's you have to work out the fluid status,
I do.
and do some more tests after that. Yeah, I know what you.
Hmm. Hmm.
So you say you. So I looked at the medication she's taking, atorvastatin. Can't blame that on
No.
it. Losartan.
Mm,
Can
I
do.
mean, it does affect the sodium and potassium sort of pathway, doesn't it? But it's not a drug that I've known to cause huge hyponatremia. What dose was she on of losartan?
50.
50. Okay, so not really a high dose. Okay.
Amlodipine.
Not known to be a big hyponatremia causer.
Lansoprazole.
Ooh, PPIs. So they can cause hyponatremia, can't they?
Yeah.
Um, so that is something that I would be conscious of. That, okay, do I need to stop the PPI? Why is she on the PPI? I'm just going to do a little rant about PPIs in the way that a lot of people have started on PPIs and they never stopped. And even if their symptoms have got better or the reason they were on it from the first place is resolved, often it's one of those medications that are continuing to be taken. So I think sometimes we need to question, do they actually need the PPI in the first place? And then if she does need the PPI, thinking about changing to another medication, famotidine, for example, that isn't going to cause hyponatremia.
And from what I remember, out of all the PPIs, lansoprazole is the least
Mm,
offensive in causing
yeah,
hyponatremia, whereas omeprazole is much more related to hyponatremia than lansoprazole.
yeah.
And the last one was thyroxine.
Okay. Not that I'm aware. I guess hypothyroidism itself can cause some sodium abnormalities, can't it? So I
Yeah.
guess in that situation, I would want to check her thyroid function and her magnesium levels as well. But if she's well and not got any particular underactive or overactive thyroid type symptoms, it's not something I'd probably be too worried about.
So that was my analysis of the drugs. And before I'd
Okay.
even got any further, I went, I'm going to knock that losartan and the lansoprazole on the head today, just for a
Yeah.
couple of days, and then I'll go and do a bit more thinking. But as I work through
Hmm.
my hyponatremia checklist, and as I say, the really big ones are the thiazide diuretics for me. And also you see it with SSRIs.
Yeah.
And if I can have a little rant, or taking in turns to rant today, I noticed that people who come in with a hyponatremia and they're taking, for example, sertraline or citalopram,
Mm,
one of the first things we do is we stop that. We go, well, stop the SSRI because they are related to hyponatremia. Just be so careful about stopping someone's SSRI very suddenly because we're
absolutely.
having a more and more understanding about discontinuation symptoms from
Mm,
SSRIs, sertraline and venlafaxine being the big ones.
yeah.
And these apparently are very awful side effects. And they're not mood side effects because, it doesn't act that quickly. But if you suddenly stop someone's SSRI, they can get horrendous, what they call brain zaps, really horrible feelings of disequilibrium, like flu-like symptoms, aches and pains. So I'm not a big one for suddenly stopping SSRIs.
I agree. Yeah.
Yeah, and then the next thing you're going to do is assess the fluid status. So I
Yes.
must please tell me. I am.
Okay.
This is one of my really areas of interest. How do you assess fluid status? Because
Mm,
I know for a fact, and this is borne out by my own anecdotal experience and by
yeah.
looking at data, is that physicians are rubbish at
Yeah, I agree.
unless someone is end of the spectrum overloaded or end of the spectrum crispy dry.
Yeah.
I've seen so many people assess a patient and say, mild hypovolemia, and the next person says a little bit dry. The next person says euvolemic. The next person
Mm,
says there's some quiet crackles. The other person says the lungs are clear. And you've got people in the
yeah.
middle who say very bizarre things like intravascularly dry but extravascularly wet, and then it gets really,
Yeah.
really crazy. But what is your approach to assessing a patient's fluid status?
Again, I agree with you, Ben. I find this really difficult actually, because it's very subjective, isn't it?
It is, yeah,
However, there are some objective measures that we can look at.
yeah.
So we can look at the patient at the end of the bed. Just have a look. Do they look well? Do they look unwell? Which is one of my favorite things to do. I'm going to have a look at their hands. I'm going to feel their hands. Are they dry? Are they sweaty? I'm going to feel their pulse. Are they tachycardic? Are they bradycardic? Have they got a normal heart rate? Skin turgor. It's often in the assessments for looking at fluid status, but again, it's quite difficult to assess. Older people tend to have decreased in skin turgidity anyway. So it's quite difficult to use that as a objective marker. Blood pressure. So are they hypotensive, which would indicate that they are fluid deplete? That's another way of looking at it. JVP, I mean, I'm not great at looking at that. I can see a JVP if it's really elevated, and you can see it sort of tickling their ear if they're really overloaded. However, it's very difficult to comment to say they're underloaded from the JVP. I might use some
Underloaded.
underloaded. I've never even used that
Love
term
it.
before. Under, suppose it's the opposite of overloaded, underloaded.
I knew what you meant.
Do you know
Yes.
what I meant? Yeah. And then I guess you could auscultate their heart and their lungs, listening to overload. So you mentioned before crackles. Again, it's very subjective. And I think as we are using more and more point of care ultrasound in our practice, I saw a patient the other day, and I auscultated the lungs and I couldn't hear anything. And then I did a POCUS ultrasound on their lungs and I saw B lines, which would suggest overload. So I'm starting to think about actually how good am I at auscultating the lungs and assessing for fluid, subtleties of fluid. You can then look at the legs. So is there any pedal edema? Huge fluid overload. I've often seen very large testicles, and testicular edema can be a problem. And sometimes you can get some sacral edema as well. The mouth dry? Is the tongue dry? Can be quite helpful. I find that when patients are really dehydrated and you ask them to pop their tongue out, it can be cracked and you can actually see the dryness in their mouth. And when you look in the mouth, when you look sort of at the side of their gums, it's very, very dry as well. And that can be a problem. Probably not the greatest assessment, to be honest. And it's not something I'm very good at. What do you do, Ben?
I think I do most of the same stuff to you. And I'm going to go through in a minute and just talk about the difficulties of all of the signs you said, because I just wrote them down. In addition to what you said, I often just say to the patient, do you feel thirsty? And if the patient says,
Yeah.
can you get me some water? I'm so thirsty. That really, to me,
Yeah.
makes me think, oh, they're a bit dry, they're underfilled.
Mm-hmm.
The other thing I often do is, I remember when I was a junior doctor, a much more junior, less experienced doctor, a resident. And
You weren't as wise.
yeah, when
Yeah.
I wasn't as old and wrinkly, I remember a consultant who says, look, the best way to work out whether your patient is dry or not is to feel the axilla. And dehydrated patients do not sweat. So they're lying in bed. The normal response when someone's lying in a hospital bed, because the way we keep hospitals, is you're a little bit moist under the armpits. He says people who are underfilled are bone dry. That's
Wow.
one of those things that just stuck with me, probably because it was such a weird thing to say.
Mm.
But not everybody's comfortable jamming your hand into other people's armpits and having a
Mm.
feel around to see if it's
Mm-hmm.
moist or not.
Mm-hmm.
But that's something that stayed with me for a while. I actually
Yeah.
looked this up this morning saying, what does the data tell us? And it says,
Mm-hmm.
this is an ancient paper from 1999 published in JAMA, How to Do Fluid Assessment. It says the one things which have a really good odds ratio for detecting hypovolemia is a more than 30 beats a minute increase in your heart rate when you go from lying to standing. Is number one. The
Okay.
other one was severe postural dizziness on going from lying to standing.
Mm-hmm.
Dry axilla, which we just mentioned.
Mm-hmm.
And it says here, capillary refill time and skin turgor is of no proven diagnostic
Yeah.
value in fluid, but we do it all the time. I taught people to do it the
Mm.
other day, medical students to do it. It's one of those things which is really
Mm.
persistent, but
Mm.
apparently there's absolutely no data behind it. What do you
Hmm.
think?
I guess that coincides with my personal experience with skin turgor. Is that actually I don't find it beneficial anyway, to be honest, because as you get older, your skin, as I mentioned before, gets slightly different anyway. And young people who might be incredibly dehydrated might have completely normal skin turgor. So again, I don't think
Yeah.
it's a great assessment. Capillary refill, it's not. It's not something I do frequently, to be honest, because again, it's incredibly subjective. So I probably have discounted those two anyway. Although similar to you, because it's probably been ingrained in my brain, I probably do still teach that we look at that. So that's something I need to think about actually.
And I was just thinking about the things that you said. You said hands, are they sweaty or are they dry? But people are stressed in hospital, they're anxious, they're nervous, they're in
Yeah.
pain, they sweat. Their
Yeah.
pulses are tachy. People are stressed in hospital. People are on beta blockers, which can suppress a tachycardia. People have got pacemakers in. Skin turgor, we mentioned, you lose a lot of skin elasticity as of age. Most of our patients are older patients. Blood pressure, people can be on antihypertensives, so you can't see it. People are stressed, so it might mask hypotension with dehydration. JVP, I think, is just a hair's breadth away from crystals and homeopathy, and from my point of view, in examining it in terms of fluid status. You said listening to the lungs. I mean, I've seen so many people who hear crackles and 2 seconds later someone else doesn't. But POCUS, I know you're a POCUS head, and I am going to have to get on board with this one of these days and learn a few ultrasound skills, can actually give us some radiographic findings, which can rule out the subjectiveness of hearing a crackle or not.
Yeah,
Edema.
absolutely.
Some people have lymphedema, some people have edema for different reasons. And mucous membranes, anyone who's on oxygen therapy has a dry
Yeah.
mucus, has a dry tongue, because oxygen dries you out. So
Mhm.
there are so many confounders and all the different aspects of fluid status. And I think, as I said before, unless someone is really soaking wet, lots of edema, or is really, really dry, I find that really hard. And that is why I find hyponatremia tricky, because you look at any algorithm, you type in
Yeah.
hyponatremia into Google, and it takes you to lots of algorithms, and they all say as the first step is, what is the patient's fluid status?
Yeah.
And I find that's really hard.
Absolutely.
It can be really hard to figure this out. And what really annoys me about these algorithms is they make it look too easy. I think they
Yeah.
oversimplify it. All you got to do is work at the fluid status, and then once you get your urinary sodiums and osmolalities, ta-da, here's your answer. My problem with that, number one, is working out the fluid status in the first instance. And my problem with that, number two, I think a lot of patients have two things going on. They're dry and on a diuretic. They're related. And that's mixed things up a bit. They've got chronic kidney disease and they've lost a lot of volume because of D&V, or they've got severe heart failure and they've also got hypocortisolemia or something. So it doesn't make any sense for the people with more than one pathology, and people have more than one pathologies because medicine is getting more complex and people don't come
Yeah.
with one single disease. So I'm like you, I have to look up those algorithms, but I have a deep, abiding mistrust of them. And I'm quite cynical about them because I think they make some assumptions which don't always bear out in real life. Do you want to know more about my patient?
Please. Because hyponatremia is something that I probably see, well, a few times a week, actually, at varying levels.
Mm.
And even after 19 years of being a doctor, I still don't feel I have a good handle on hyponatremia.
So I assessed the patient, I asked the questions, and I tried to make an evaluation of fluid status. Blood pressure, 130/81. Heart rate, 62. SATs, 95%. Respiratory rate, 19 breaths per minute. Temperature is 36.1 degrees. Fluid status, the JVP was not raised. I can tell you that. There was bilateral pedal edema to the knees. And she said, I've had that for ages. That's lymphedema secondary to the cancer. So I can't really draw any attribution lines between fluid status and that finding. Her tongue was moist. Skin turgor to me felt normal. I looked at her blood tests. The sodium was confirmed at 119. The potassium was 5.4 and the creatinine was 122. And the last time we measured them a couple of months ago was 80. So that's AKI territory.
Okay.
Her FBC revealed a hemoglobin of 80, which is actually her baseline. And as part of her condition, she has regular hematuria and is now transfusion dependent. So 80 is actually normal for her. Her platelets were 360, her white cells are 4.1, CRP was 16, and the urea, which we don't get routinely in our trust, you have to ring up and add it on, was 10.9. So
Okay.
I had to make a couple of decisions there at the bedside. And the decision is always with hyponatremia, what are we going to do with regards to water? Now, if someone's got mild hyponatremia, sort of 127 and above, in the context of lots of other acute illnesses, my approach is very much let the patient drink when they're thirsty, treat everything else, and I betcha it'll normalize. Homeostasis will kick in once we've treated the sepsis or the pneumonia or the whatever. And it does. It tends to, without any focus, it tends to improve over time. 119, a bit too low just to leave it. I want to do something dynamic here on the post-take ward round to address it. So what are my options? Fluid restrictor, give her fluid, saline, normal saline, give her hypertonic saline, give her diuretics, or let her drink to thirst and see what happens. Hold the PPI and the ARB, the losartan, easy peasy. I said, of course, get a urinary sodium and a urinary osmolality, because that is part of how we work up hyponatremia. Is she losing sodium inappropriately from her kidneys? Is she concentrating urine? Is it an ADH problem? Because SIADH is something you would fluid restrict or not. And get a bladder scan, because I think she's got an AKI. I don't want to assume it is a pre-renal. She's got a bladder mass, a bladder cancer. So let's just make sure she's not in urinary retention. And that's why she's an AKI. And that's what's throwing everything out of whack. I should note as well, I did ask her about fluid intake, and she said she thinks she drinks about 2 liters a day, including teas and coffees. And she hasn't experienced any fluid loss, any horrible D&V or polyuria. So I couldn't really attribute it to a hypovolemic state. So I said, I think, well, hang on, I'm going to stop. What would you do? Or would you, or you don't want to make a call?
I feel like an MCQ, like A, would you do this? B, C. These are tricky. So what would I do in this situation? I struggle with fluid restriction when I don't have a formal diagnosis of SIADH without the urinary sodium and osmolality and the plasma osmolality, because often the patients I see who have hyponatremia tend to be quite old and elderly. They generally fluid restrict themselves anyway. And I struggle then to tell them just drink a litre of fluid a day. And they often drink, 10 mils a day or something crazy and become really, really dehydrated. So what would I do in this situation? I wouldn't fluid restrict her. I wouldn't give her any fluid. I'd probably tell her to drink as normal. And I would probably send her home and repeat the sodium in a couple of days, which is probably the completely wrong thing to do. But she's well. She got an Uber to hospital or a taxi to hospital. Hospitals are dangerous places. They can cause infections, hospital-acquired infections. You've got the risk of venous thromboembolism. So I'd want her to be in hospital as short a time as possible. So I'd probably say, okay, your sodium's a bit low. I'm going to stop this medication. Drink as normal. I'll see you in 3 days and follow up.
Thank you. I'm so glad you said that, because I think it's a really lovely example about how you can get a whole bunch of pretty experienced doctors to see a patient, make a call, and come up with completely different plans. I think that just emphasizes the fact that in medicine, very often there isn't an MCQ answer. It isn't the right answer, and you did it right, you did it wrong. It's just a judgment call based on your intelligence and what you've gathered over the last few hours and over the years as well. So what I did, I thought sodium's 119. That's severe hyponatremia. She's got an AKI. I'm gonna decide. I decided I'm gonna give her some fluid, and here's why.
Okay.
I thought, even though to me she could be a bit dry, she could be euvolemic. She's not overloaded, I'm sure. And I think the AKI with the slightly raised urea speaks to me of mild volume depletion. I ruled out obstruction because the bladder scan showed no urinary retention. So I thought, I wonder if she might be a bit dry. I'm going to give a very, very slow normal saline. So I prescribed normal saline over 12 hours. And I said, and this was in the evening, I said, and let's do a sodium first thing tomorrow after this very slow bag of fluids. And we'll see what happens. And as I said to the SHOs with me, and I say, and if tomorrow it was the wrong thing to do, I'll give her some frusemide and undo it. No harm, no foul. But so it was half treatment, half investigation to see what. And I kept her in, and I stopped those 2 offending drugs. And that was my decision. The one thing I am pretty clear about in these cases of severe hyponatremia is when to give hypotonic saline, because the guidance actually, that's easy peasy. It says, I don't care what the cause is, give hypotonic saline if they get confused, drowsy, i.e. if there's any central nervous system. And I find that quite easy. I can do that no problemo. And she didn't have any of the above. So I just gave normal saline, 0.9%.
Yeah. And I'd certainly in some hospitals, we have to give hypertonic saline in the intensive care setting or the high dependency unit. Some hospitals do, some hospitals don't. So if you are going to be given that, it's just worth checking what your hospital guidelines are as to where you can give the hypertonic saline. Yeah.
Absolutely. So I prescribed the fluid. I go home. I come back in the next day, and her sodium had gone down from 119 to 115.
So you've diluted the plasma and you've made it.
put the sodium down. And at this point, I have a few more results back. I've got the thyroid function, which is normal. I've got a
Okay,
cortisol,
good.
which is normal, 600. So that ruled out Addison.
Yeah.
And I've got the urinary sodium and the urinary osmolality.
Oh. I get palpitations when I hear those two words because I always forget,
Yeah.
as I've mentioned, how to interpret them. And I say I'll remember them for like 20 minutes and then I'll forget them for another 20 minutes. So, yeah. So tell me what they were and how you'd figure them out.
I'll talk you through how I did. And look, I
Thank
looked it
you.
up. I looked it up. This didn't come out on my own.
Okay.
So,
It's reassuring.
yeah, the urinary sodium was 30 and the urinary osmolality was 256. Now, whilst I knew that urinary osmolality in lay terms for my lay brain, I was like, osmolality is how concentrated the urine and how dilute it is. One thing that really helped me was when someone said to me very recently, it says, if you're struggling to conceptualize what urine osmolality means, urine osmolality is our surrogate for serum ADH levels because we can't measure them. So low urine osmolality means the patient has low levels of ADH, antidiuretic hormone. High urine osmolality means they've got high levels of circulating ADH. And that was a bit of a breakthrough for me because I was like,
Me too.
oh, now I can.
Yeah.
So so we know that someone who's got a urine osmolality, and by the way, the cutoff for urine osmolality is 100. And you can remember that because visualize the number 100, one with two big zeros after it. Those big zeros in 100, they kind of look like the letter O. So O for osmolality. So 100 is the cutoff osmolality. So
Okay.
256, that's
High.
high.
Yeah.
That means, forget osmolality, that means the patient has high levels of ADH.
DH.
You might say inappropriate
SIADH.
high. You might say they have some kind of syndrome of inappropriately releasing ADH. ADH. So that was the ultimate diagnosis, and the urinary sodium being 30.
Okay.
I still have to look at the algorithm and remind myself all the bits and pieces about that. But the endocrine team came and reviewed, and they wrote a little note, and it said, impression, SIADH, euvolemic patient, sodium fallen overnight due to inappropriate fluid therapy. Plan fluid restrict. Feelings. No, it doesn't bother me in the slightest. But it made me think a lot about what we've said about before on the podcast, second reviewer syndrome. When someone comes along later in the patient's story with data that you didn't at the front door and having witnessed what you've tried and see if that was successful or not, it's very easy to come on later and say, well, clearly it's option B because we've got with option A. But when I was presented with A and B, that's information. So I don't give myself too hard a time about that. This is something you're familiar with, right?
Oh, it happens to me all the time. It's really interesting because I think as an acute physician at the front door, we are making decisions on little information. Like you said, we don't have all of the investigations, we don't have all of the tests. And what you say often is one of the most important things we can use in a patient is vitamin T, vitamin time. And actually, sometimes 12, 24 hours in hospital helps us to see what's happening with the patient journey. Are they deteriorating? Are they getting better? And at the front door, you don't have the benefit of time. And we have to make clinical decisions with very little information, very little time. And it can be incredibly difficult to do that. So, but again, we are still very hard on ourselves because this often happens where I've made a decision 2 days down the line, the specialty comes in and says, why on earth did Dr. Burbridge say that? It was clearly this patient has adult onset Still's disease. It's clear 2 days down the line, but on admission, when we didn't have any investigations, that is incredibly difficult. But I do still probably beat myself up about it quite a lot, actually, when I don't get things right at the front door.
And I would add to that and say, when you are writing in patients' notes, just be a bit mindful and be a bit careful. I'm not even talking about hurt feelings here because we're all skinned enough, but it's just be careful what you write. And there's no need to be unnecessary accusatory or to sort of imply failure or stupidity on behalf of your colleagues. Just it's a medical legal document, so try and keep it as factual as you can.
And just on that note, Ben, I a couple of weeks ago, I was doing a ward round on a Monday, and a patient had come in on the Saturday or the Sunday, and had a peg tube had fallen out. and documented in the notes by a team member from a specialty was, I do not understand why the acute physicians have managed the patient like this. This is entirely inappropriate. And basically, similar was unnecessarily rude. And I actually contacted the person who wrote in the notes and was just said, can I just give you a little bit of feedback? But I've just read these notes. And actually, I'm quite upset about it because we're all trying to do our best. And I think the way that you've documented comes across as we aren't trying to do that. So just on reflection, have a look at what you've read, because it's obviously on computer, it's all there. Maybe
Mm.
next time you are cross and you're frustrated because you think we've done the wrong thing, but maybe write it out and delete it. It's like those emails that you want to send. And 10 years ago, I would have sent them, but now I write them and go, clearly, I can't send that. Put them in my draft box. And I think it's really important, actually, to call out that behavior, because incivility at work, that really affected me that day. And I think if you see it and witness it and read it, it can affect the people around you as well.
That's
Um,
absolutely true. Not only does incivility, and from a human factors point of view,
mhm,
affect the person it's being projected at, which, by the way, affects patient care and patient safety.
absolutely.
So there is very strong data, and I know this because I teach this in my simulation courses, that even if you witness incivility
Yeah.
happening over there to somebody else, it affects your
Yeah.
performance and it
Yeah.
affects what happens to your patients. So there is actually a really big deleterious effect on for incivility, even from
Mm.
bystanders and from seeing
Mhm.
it.
Yeah.
And it's something, it's such an easy fix. Just
Yeah.
don't do it.
Yeah.
Either
Yeah.
face to face or on the notes.
Yeah.
But my patient, her sodium incremented to 118, and then she had a couple of boluses of hypertonic saline. They restricted it down to 500
Ooh.
mils a day, and
Okay.
eventually it normalized. And she got better. But I thought this was an interesting case because I find the approach to hyponatremia is extremely heterogeneous, depending on who's seeing the patient. It calls for you to make some judgments about a clinical status, which are really, there's a big inter-observer variability between them. But according to the algorithms we use, you can't start making treatment plans and interpreting the other parts of your assessment until you've made that call first off. And I like the bit about if you're getting stuck on what urine osmolality means, it just means how much ADH have they got in this in their system. And that's a surrogate we're using. And I found that really useful because it was quite an abstract concept to me. Osmolality, I didn't really get it in medical school. I didn't really get it now.
So, can I just challenge back a little bit? So, this lady had an incidental finding of a low sodium that wasn't causing her any symptomatology.
Yeah.
Did you find out the cause of it?
It was attributed to SIADH in the context of metastatic cancer,
Okay.
which also
Okay.
she had lung mets in a part of the event.
Okay.
Yeah.
So, moving forward, the metastatic cancer is not going to go away. So, how are we going to manage the low sodium? And do we need to manage the low sodium with such strict fluid restriction at home? Is this going to affect her quality of life? Because obviously 500 mils isn't very much. Or is she going to go home on a medication long term? Is it DDAVP, vasopressin, that actually is going to stop her from going into the hyponatremia again, potentially?
Well, from what I understand, the aggressive fluid status you do to normalize the sodium, and that plays a
Yeah.
role in sort of resetting their internal osmostat. So you
Yeah.
can relax it a bit after, but she will be fluid sensitive, I think, moving.
Mm.
She'll have to be mindful for, but I don't think she'll have to maintain a 500
No,
going.
no, no, no. That's more of the acute management, isn't it?
Yeah.
Yeah.
Medications wise, I remember the Vaptans, Tolvaptan and such like.
Tolvaptan. Yeah.
Yeah. Which was cost about £4 million a molecule, and it could only be signed off by an endocrinologist or whatever. But I don't really see that in clinical practice. When I was
No.
brand new, we used to give democlocycline, which is an antibiotic
Yes.
side effect of inducing a little bit of diabetes insipidus, which you used to counteract the SIDH. That went away because it's sort of you're getting a place. Let's give you someone a new drug with a new side effect to counteract the first disease, and it's like you're just giving the patient more and more comorbidity. But I don't see that used anymore. But I don't see tolvaptans prescribed very much. I think most of these patients end up being on some kind of fluid restriction, albeit not so
Mm.
rigorous. And it also depends where they are in their cancer journey. If someone is coming to the end of life and we're prioritizing symptoms and quality of life over any treatment, then of course you can say, go home and be happy, drink tea and coffee and whatever you fancy, and make whatever time you have you left. And we just won't measure your sodium anymore. And then it isn't a problem. But if someone's prognosis is months to years and their priority is staying out of hospital and staying well and not having horrible hyponatremic
Of course.
cognitive clouding,
Yeah.
sickness, nausea, loss of appetite, then you would address it, I
Yeah.
guess.
Yeah, of course. Yeah, that makes sense. Really interesting case in the fact that we're both acute physicians. We qualified around the same time and we manage completely differently. Where a lot of cases we have a very similar management strategy. But
Yeah,
hyponatremia is one of those things that you could put 10 doctors in a room and you'd have 10 management plans,
yeah. I think you could
probably.
put 10 endocrinologists in a room and have 10
Yeah.
plans, by the way. You
Yeah.
know, when we have endocrinology consults and they come to see our patients with really
Yeah.
bad hyponatremia, I don't think I've seen the same plan twice. So
Yeah. That's an
I think
interesting
there's
point, actually. Yeah.
variability there. And it just goes to emphasize that there isn't always, people think there's a right thing to do and what they're doing is the right thing to do, but I don't. It's often the right
Yeah.
thing. It's sort of
Yeah.
patient specific.
And I think that's also reflected in the fact that the guidelines for hyponatremia haven't been updated since 2014.
Mm,
So it's 10 years. That was the European Society of Endocrinology. It was published in the European Journal of Endocrinology in 2014. So for 10 years, we've been doing the same thing. So really interesting. I think one of the key things I want to take away from this is a high urine osmolality tells me that there's a high ADH. That has
yeah.
completely changed my working
I like that.
practice.
It's good, isn't it?
Yeah,
It's really
it's
good. Yeah.
fantastic. And it's a really easy way of remembering something
Yeah.
actually.
Yeah.
And it will hopefully help me on the journey of hyponatremia. What do you do in cases? We probably see a lot of patients who come into same day emergency care with a sodium of around 124, 125, an incidental finding. They're not in that severe category. What do you do in the situation?
Well, I do what I said at the top of the podcast. I go to the
Mm,
drugs, first of all,
yeah, drugs.
and
Yeah.
say, oh gosh, this is something we've done. It'll be iatrogenic. And if it's not, then I have another think. And we try and make a judgment about
Mm,
fluid status and what they're
mm.
drinking. I don't have a threshold for admission.
Okay.
I think everyone have a different threshold for that as
Mhm.
well. Um, I am affected by a previous case bias in that
Okay.
I saw someone with moderate hyponatremia of something like 125-ish. So not
Okay.
severe, come to a very, very tragic end with it.
Oh,
And that does affect how
of
I
course.
now um, manage in terms of inpatient versus outpatient.
Mm.
I'm trying to think if I have a criteria for admission. I think I'd be happy with a 127 being ambulated,
Okay.
a 126.
Yeah.
Yeah, I think so. And also
Okay.
chronicity. If their baseline sodium is
Yeah.
always one,
Of course.
known SIDH, then everything gets adjusted for that.
Mhm. And I think one thing we haven't mentioned yet is, and I think the fact that I'm always very cautious about managing hyponatremia is my case bias, is that I had a patient with a low sodium and their sodium was corrected too quickly and they had
Mm,
osmotic demyelination.
mm,
And that was devastating as well for the patient. And I think so I think that's always weighing on my mind as a low sodium, hypertonic saline. Oh gosh, we corrected the sodium too quickly, and now it's had a really significant detrimental effect. So you're right, with every case we see, there's always that case bias, isn't there? That
yeah.
hindsight bias. And I think that's something that we need to be cautious of is don't correct too quickly because of the risk of osmotic demyelination, which can have significant cognitive
Mm.
effects.
And I think because I've seen that one case as well. I've seen one case in my career of that.
Yeah. Yeah.
Doing my, and I think the guidance is don't correct the sodium.
Mm.
Is it more than 10 to 12 millimoles in 24 hours?
Yes. Yeah.
I would be slower than that.
Me
I
too now. Yeah.
go for like 5 or 6 in a
Yeah.
day or something like
Yeah.
that. Yeah.
Yeah. Yeah. And I think, again, we've talked about this before, where the earlier on in my career, I was a little bit more, not gung ho, but a little bit more confident with my decisions because I probably didn't have as many cases in my background to compare to.
Yeah.
But
Yeah.
now I've got 19 years of them. I'm like, oh, I've seen this, I've seen this, I've seen that.
Yeah.
I'm going to be a little bit more cautious. It's the same with steroid usage. I'm a little bit more reluctant now to go for those big, big doses because I've seen, again, detrimental side effects. And I think is case bias a good thing? I don't know. Does it stop me from managing patients properly? I don't know. What do you think?
Fine properly. I think
Oh,
makes us it makes us safer in many ways, I think.
yeah,
I think
yeah.
there is definitely positives to it. I think
Mm,
where it becomes sort of pathological is when someone has been burned so horribly by a previous case
yeah,
that
yeah,
it materially alters how they manage every single presentation of the same diagnosis for the rest of their career, which then
yeah,
maybe exposes the patient to unnecessary tests or
yeah,
inpatient. So I think once it starts impacting patient care,
yeah,
that's when maybe it is not working for you.
yeah,
Or if you had a case of a patient who received some treatment and survived, if it makes you a bit too gung ho and a bit laid back,
yeah.
saying, "I'm going to send them home, I'm sure they'll be fine." That one case, they were fine.
That's a
So
good point.
it also depends on what's happening at a patient
Yeah.
level.
And I think actually brought into something that I hadn't thought about for a while is I'm very much of the case bias in the fact that I've missed something and, I'm going to over treat. But what you've just said is that if I manage something and under manage them or do something, oh, they're fine, they can go home, I don't need to do that and they're fine. Does that then lead me to under treating other patients potentially?
Mhm.
I don't know. Probably, actually. Yeah.
This is why we try to remain reflective,
Mm.
insightful practitioners and think about
Hmm.
metacognition and thinking about thinking and
Yeah.
think about not only what decision do I need to make, but why am I making this
Why am I
decision?
making it?
Yeah.
Yeah. Absolutely. And discussing them. So I know we discussed them on the podcast, but also I had a case at work last week and I just didn't know what to do. And it was a very well patient. And I went and got my colleague Simon and I sent him a message saying, can I please have a second opinion? And he was like, okay. And I just don't know what to do. And he came in the room and we saw the patient together and it was a headache, query subarachnoid, those really difficult decisions for me. And he'd spoke to her and he said, actually, I don't think this is. I agree with you, Amy. However, I couldn't make the decision. I needed a second opinion. And then afterwards, we spoke about the case for about 10 minutes. So we'd spent about 1 hour discussing one case because I couldn't make a decision. And I think it's really important as consultants when we can't make decisions, it's okay to ask for help.
So, listeners, if you are doctors
Mhm.
and one day you will be applying for a consultant or an SAS position, think about the team you'll be working with.
Oh, 100%.
Are these people who I can count on to
Mm.
support me and help me out with my patient care?
Yeah.
And I think that's a really important question to ask yourself when you're trying to
Yeah.
visualize where you'll fit into the NHS workforce at a senior level and what the right hospital is for you, or clinic,
Yeah.
department, or GP surgery.
Absolutely. And when I talk to people who are on the journey of, going for a senior position in a hospital, I'll say to them, the hospital's important, but the most important thing to me personally is who I work with and my colleagues. And I know that I can go into work tomorrow and ask any one of my colleagues and say, can I have some advice? Can I get a second opinion? Can you look at this ECG for me? I did it
Mm.
again last week with query pericarditis. And it's just so nice to have that connection with your colleagues at work. Really, really helpful.
Agreed. Okay. Thank you very much, Amy. I hope you've
Thank you,
enjoyed
Ben.
my case. It was a bit of a weird one today because it was not working out the diagnosis, but
Mm,
I think this is still useful to, because
100%.
sometimes you are presented with a sort of an endpoint, a diagnosis. You've got to work out how you're
Mm,
going to get there. And it's always
mm,
useful to hear different opinion. I think useful for other people to hear different
mhm.
approaches. Thank you very much, everybody, for listening. Hope you're enjoying the podcast. As Amy always says, please do leave us a review, tell your friends about it. This is how the podcast grows and we reach more people. And if you want to come and see us as we talk through these to prove that these really are cases we have not discussed before by our horrified looks and frantic hand signals as we do this, we have a YouTube channel now because some people are just more visual when they learn and they want to see what's going on. Thank you so much, Amy, for being my podcast partner today.
Thank you, Ben. I've loved it, as ever.
And I'll see you all next time. Bye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.